Hello, good day everyone. Welcome to Edward's Clinical Education virtual course. Thank you so much for spending a few hours of your Saturday with us. In this session, changing the pace of hemodynamic monitoring, predictive monitoring for management of hypotension in OR, we are privileged to bring you two clinicians, Associate Professor Ng Xin Yi from Singapore and Professor Thomas Schreen from Netherlands, to discuss on the frontier of utilizing AI for predictive monitoring in the clinical settings. Now, before we begin, we will have Slido enabled throughout the session for any engaging posts or questions you have for Prof. Schreen. Just use your phone, scan the QR code over here, and the post will be automated as the session goes. At any time, you can always drop in your questions for the Q&A session later. Now, it is my honor to introduce our chairperson for today, Clinical Associate Prof. Ng Xin Yi. Associate Professor Ng Xin Yi is the head of department and senior consultant anesthesiologist and intensivist at the Department of Surgical Intensive Care in Singapore General Hospital. He is also the co-chairman of the Campus ICU Committee. Associate Prof. Ng is also the member of the Subspecialty Training Committee of Intensive Care Medicine, as well as examiner for the Masters of Medicine Anesthesiology and the exit examinations for Intensive Care Medicine. He is also a board member of the Chapter of Intensivists, Academy of Medicine Singapore. He has special interest in point-of-care critical care ultrasound, as well as hemodynamic monitoring. As for research, he has published on airway management, sedation in the ICU, and outcomes after critical illness. Now, it is my pleasure to welcome Associate Prof. Ng Xin Yi.
Thank you, Hansel. Thank you to the audience out there for joining us this afternoon to this event organized by Edwards Life Science and Singapore Society of Anesthesiologists. And I'm honored to be given the opportunity to chair as well as moderate the questions with Prof. Schreen later. Okay, so our speaker today needs no introduction. He is a famous clinician as well as a researcher in the area of hemodynamic monitoring. You may have read many of his publications in the top anesthesiology as well as ICU journals. So Professor Thomas Schreen is currently working as a full professor in the University of Groningen, the Netherlands. He's also an expert on hemodynamic monitoring, echocardiography, microcirculation, and tissue oxygenation. So without further ado, let me invite him to give his talk on changing the pace of hemodynamic monitoring, predictive monitoring for management of hypotension in the operating room. Schreen, please, the stage is yours.
Thank you very much for this kind introduction, and also thank you very much for Edwards Life Sciences to organize this meeting. When we are talking about hypotension, we have to know what is hypotension. In my first question, I would like to ask you, what is the best definition of intraoperative arterial hypotension? Is it a systolic arterial pressure of below 90 millimeters of mercury? Or is it a mean arterial pressure below 50 millimeters of mercury? Or is it a mean arterial pressure below 65? Or is it a decrease of more than 20% of mean arterial pressure from the individual baseline of your patient? Or is it option E, there is no universal definition of intraoperative arterial hypertension? So please go to your Slido and give your option now, please. Okay, I can see that most of you choose for option E, that is, there is no universal definition, and that is the correct answer. So I'm proud, I'm very happy to see that you are already up to date. But those of you who choose answer C is also fine. So also a mean arterial pressure of 65 is a good idea. It's the most commonly used definition, and we will come to that later. So I'm very glad to see that you are already up to date. And let's look at the literature. So this is a group also from the Netherlands who look at the literature definitions of intraoperative hypotension. And they found 140 definitions for hypotension in 130 articles. So more definitions than articles. It's like more opinions than doctors. But the most common one were systolic pressure below 80 in 41%. Most of them had a systolic, at least one episode of systolic blood pressure more than 20% per baseline. And depending on the definition that you use, you can find incidences of hypertension varying from as low as 5% up to 99%. And with that, we come to my second question. So what do you think is the incidence of intraoperative hypertension in your hospital if we take one of these definitions, let's say a mean arterial pressure below 65 for more than 1 minute? So would you say it is A, between 20 and 40%, or B, between 40 and 60%, or C, 60 to 80%? Or D, more than 80%, or would you say, oh, I'm such a good anesthesiologist, I can prevent hypertension, so the incidence in my hospital is negligible? So please go to the Slido again and choose your option. Okay, the voting is closed. So this is very interesting. So there's a broad spectrum of answers this time. But again, most of you saying that the incidence is high, so more than 80%. This is actually a very high incidence. I would say that was much too high incidence. But then we looked at our data, and this is a study we just published last year. We looked in 255 patients undergoing major abdominal surgery, and all of them received goal-directed fluid therapy. So they were optimized in terms of volume and flow. So we got a lot of data points. And actually, we found that despite having goal-directed therapy, the incidence of hypertension was above 80%. So 86.7% of our patients had at least one hypertensive event defined as a mean arterial pressure below 65 for more than 1 minute. In total, we recorded more than 2,200 hypertensive events. The median number of events per patient was 4, with a range between 1 and 9. The median duration of every event was 2 minutes per event, also with a range between 1 and 5 minutes. And if you add this up during the case, the duration was 11 minutes of hypertension, again with a range between 3 and 38 minutes. And this equals to 6% of the total case time in our patients. So this was quite shocking to me when I saw this. The question was, are we that bad in Groningen? But from the poll, I see that most of you also similar experience. And I found another study. This is a study from Germany where they looked at 100 patients undergoing hip surgery. And again, they looked at, and if you just look at the control group, again, they have a incidence of intraoperative hypertension of 88%, and they see 5 hypertensive events per hour, lasting about 11 minutes. And this is again 6% of the case time in that hospital. So this is pretty similar to what we found in Groningen. So I think we can generalize these findings. So if you look at hypertension, you will find it in your records. And this is quite a high incidence. So is this related to outcome? And which outcomes are we interested in? Of course, mortality, death, but also kidney injury, myocardial injury, and cerebral outcomes such as stroke, delirium, or POCD. So let's look into literature. This is a study published some years ago looking at more than 33,000 non-cardiac surgeries, and they looked at mean arterial pressure threshold below 55 millimeters of mercury in that study. And they could show, and they looked at different outcomes like acute kidney injury and cardiac complications. And you can see here very clearly, the longer the hypertensive event was, the higher was the incidence, the odds ratio of developing any of these complications. But even short periods of intraoperative hypertension, so 1 to 5 minutes, were already associated with a significant increase in the odds ratio of these complications. This is a study from Europe, published recently, more than 10,000 patients, and they looked at different definitions of measurements of hypertension, mostly systolic pressure below 80 or mean arterial pressure below 60. And again, they found that all intraoperative hypotension markers for these thresholds were significantly associated with an increased 30-day mortality. And this is a very big study from the Cleveland Clinic, more than 100,000 patients having non-cardiac surgery. And again, they looked at the association between the time-weighted average of mean arterial pressure or the minimum mean arterial pressure and 30-day mortality. First of all, you can see that the lowest mortality was associated with a mean arterial pressure between 75 and 95, and that this incidence is increasing dramatically as the blood pressure lowers. And this, you have to realize that this is a logarithmic scale, so this is a dramatic increase in mortality with decreasing blood pressure. And this is another study from a different center, more than 150,000 patients having non-cardiac surgery. And this is a three-dimensional plot. This axis, you see the time spent at a mean arterial pressure below certain thresholds. This is the cumulative minutes on this axis, and this is the incidence of 30-day mortality. And as you can see here, the lower the mean arterial pressure, the sharper was the increase in mortality. And if you look very closely, you see here actually two planes. One is for the normotensive patients, and the other one is for patients that had hypertension, chronic hypertension prior to surgery. And in those patients, less time was required to be accumulated for the increased mortality. So maybe in patients with prior hypertension, we need even higher blood pressures, and this may be due to the shift in the autoregulation curve of their organ perfusion to the right, as we can see here. Coming back to the organ outcomes, this study, again from the Cleveland Clinic, now looking at 164,000 patients having non-cardiac surgery, and they looked at myocardial injury on the left plane and kidney outcomes, so acute kidney injury on the right side. And for both planes, you can see as the blood pressure lowers, if blood pressure decreases below 65, this is the 65 threshold, the odds ratio for myocardial injury dramatically increases, and the longer the time, the higher the increase. And the same is true for acute kidney injury. Again, as the blood pressure decreases below 65, the incidence dramatically increases. And this is the biggest study that has been published so far, published recently in ANA, 368,000 patients having non-cardiac surgery over 10 years period. They looked at different outcomes, including mortality, myocardial injury, and stroke. And you can see here, this is a relation to age. Intraoperative hypotension was significantly associated with this primary anchor for all the age groups and all thresholds. So these are different thresholds that they looked at. This is the 65 threshold, but you can see for all the age groups, there was an increased significance odds ratio. And it was also associated, here are the different outcomes like acute kidney injury, acute myocardial infarction. The lower the threshold, the higher the incidence. 30-day mortality, delirium is here, 90-day mortality, sepsis. All of that except for stroke. This is stroke. This was not associated with hypotension. So they conclude that intraoperative hypertension is a serious public health issue that should not be ignored for any age group. And this is a meta-analysis also coming from the Netherlands, published 2 years ago in the BGA. They found 42 articles looking at hypertension and outcome. And this is a table of the outcomes. So are the different outcomes: mortality, acute kidney injury, myocardial injury, overall organ injury. And these are the different mean arterial pressure thresholds from 80 to below 40. And the color code says the darker the color, the higher is the odds ratio. And you can see here, as soon as the blood pressure goes below 65, incidence increases, and as at low blood pressures, there are high odds ratios for developing any of these outcomes. So organ injury might occur even at higher blood pressures below 80 for more than 10 minutes, and it progressively increases as the blood pressure decreases further. And this led to this consensus statement from the POCI initiative, Perioperative Qualitative Initiative on Elective Outcomes for Elective Surgery, and they recommend that the mean arterial pressure should not be below 60 to 70 because this is associated with myocardial injury, acute kidney injury, and death. And the same is true for systolic arterial pressures below 100. So if we can summarize up to this point, we can say that the definition of hypotension is variable, but that the threshold of a mean arterial pressure below 65 appears to be where the harm starts to occur. An intraoperative hypotension defined with this threshold of mean arterial pressure below 65 is very common. The incidence is more than 80%. It is associated with poor outcomes, myocardial injury, renal injury, maybe stroke, and certainly mortality. The lower the mean arterial pressure and the longer the duration, the higher is the risk of harm. So we have to do something about it. And the hypothesis is that when we reduce this hypotensive burden, that we may be able to improve the outcome of our patients. And that brings me to the second part, or the core of my talk, is how can we predict hypotension? Because when we predict hypotension before it even occurs, we might gain some time to treat the patient and prevent this hypotension from occurring. So let's look into the pathophysiology of hypotension. So when the hypotension becomes clinically significant, so that when there are clinical signs of hypotension, this is not the origin of the hypotension. This is when all the compensatory mechanisms of the organism fail and the patient blood pressure drops. But the reason for the hypotension is in the past. And it would be very nice to see already at this point that a hypotensive event will occur, so that we will not have a delay with our therapeutic intervention. Because as we saw, the risk for hypotension-induced organ failure increases over this time period. And the problem is that the real-time monitoring that we have at this moment is very good in telling us if our patient is stable or not at this very moment, but it is not good at looking into the near future, so detecting or predicting instability at an early time point. So this is what we have to change. And if we are talking about predicting hypotension, we can look at the arterial pressure waveform, like you can see here. And if we exaggerate here one heartbeat, one full cardiac cycle waveform, you can see here, and there is a lot of information hidden in such a waveform, like information on the contractility in the upstroke part. The stroke volume is hidden here in the area under this curve. This part gives you information about the aortic compliance. This is the afterload, and this is representing the vascular tone. This is something that you cannot see with your eye just by looking at the monitor. You need computers to look at this. And this brings us to the big field of machine learning, artificial intelligence. We need big data for that to come up finally with a predictive algorithm that can predict an event, in this case, hypotension. And this has been done by people from Edwards Life Sciences, published 2 years ago in Anesthesiology, and they called it the Hypotension Prediction Index, HPI, which is based on machine learning. So how does it work? Actually, as I told you, they looked at the arterial pressure waveform. They divided that single arterial pressure waveform into different parts, which they then combined to get more than 3,000 individual features from this arterial pressure waveform. And if you combine these features, you end up with more than 2.6 million combinations, which they fed into their model and let the machine train the model. And they came up with a final prediction model, which they then tested and validated. And this was called the Hypotension Prediction Index. This is just a number between 0 and 100. So a low number like this here in green would say that the probability of a hypotensive event is low in the near future, whereas when this number is high, like here in red, it's a very great likelihood that this patient will be hypotensive in the next minutes. And of course, they validated this new algorithm, as you can see here. They looked at a lot of patients from the ICU, from the OR. They also took patients from the MIMIC database, where they trained their algorithm, cross-validated and internally validated it, but they also had patients from external source from a university hospital where they did the external validation. And this is the results. This is the internal validation. And this is a receiver operating characteristics analysis that you might be aware of. And the greater the area under this curve, the better is the predictive ability. And here you see the predictive ability of the HPI, the red line, 5 minutes, 10 minutes, and 15 minutes before the occurrence of a hypotensive event. And you can see that the predictive ability is very good. And it looks similar in the external validation of their data. And this is a case that has been published in this paper, which is very interesting. I would say this is a case from abdominal surgery. The patient has a mean arterial pressure of 85 here. And at some point here, the mean arterial pressure drops to 75, but it stays still below this threshold of 65, which is here the dotted line. But at this point, the HPI goes up, telling you that there will be a hypotensive event. But actually, in this case, it took 17 minutes until the blood pressure actually dropped below the 65 millimeters of mercury threshold. So these 17 minutes could have been used to detect the hypotension early and to think about the reason behind the hypotension and think about some measures to treat or prevent this hypotension from occurring. We also looked at the performance of the hypotension index. How good is it in predicting hypotension? And we found that actually the higher this HPI value is, the higher is the actual event rate. So this is saying that when the HPI is high, you can be sure that the hypotension will occur. And we found higher the value, the shorter is the time to that event. So if you have a high value, you can be sure that hypotension will occur within the next couple of minutes. Now you might say, oh, I don't need this stuff. I'm an experienced clinician. I can predict hypotension by just looking at the blood pressure or the development of blood pressure. And maybe you are right. So this is just a screenshot from the monitor, looking at mean arterial pressure. And if you see a development like this, and you put here your 65 thresholds, you might extrapolate this and say, okay, I can predict at this point the blood pressure will drop below 65. So I don't need this fancy number like HPI to tell me that this will occur. And actually, this is how it goes. So the question is that we have to answer, is HPI just a mirror of mean arterial pressure or the changes in mean arterial pressure? If that would be the case, it would not be of additional value. I hope you will agree. So we looked at that, like the people from Edwards Life Sciences did in their validation study. Again, these are receiver operating characteristics curves for the HPI at different time points. So this is 0 minutes. This is when the hypotension occurs. Of course, then the HPI always was positive, so 100% predictive ability. And this is 5 minutes, 10 minutes, and 15 minutes before the actual events. And as in the Edwards paper, we also could reproduce that the predictive ability of HPI was very good. And now let's look at the changes in mean arterial pressure. So this is mean arterial pressure changes at the moment that hypotension occurs, less good than HPI. And this is the values 5, 10, and 15 minutes before the occurrence of hypotension. So as you can see, this is just like flipping the coin. This is no predictive ability at all. So changes in mean arterial pressure some time before the hypotension do not reliably predict hypotension at all. And we did the same for any other hemodynamic variable that you might think of: cardiac output, stroke volume, mean arterial pressure, pulse pressure, heart rate, stroke volume variation. We even calculated the shock index. And none of these variables were as good as the HPI, the red line, in predicting hypotension. This is the values 5 minutes before the event, but the values 10 minutes and 50 minutes just look pretty much the same. They are in the paper. If you're interested, you can find them there. And this is a case that I did. It's an off-pump coronary artery bypass grafting. And again, I was blinded to the readings of the HPI, which is shown here. But here you see the mean arterial pressure going down. At this point, the HPI was alarming, would have told me that the hypotensive event would occur in the near future, but it took, and again, like in the case in the Edwards paper, it takes 16 minutes before the blood pressure actually dropped below 65 after some time. So I decided to start norepinephrine, but until it was prepared and started, it took some time. So in the end, the patient was hypotensive for 7 minutes. And again, this 7 minutes of hypotension might have been avoided if I had seen this HPI value telling me 16 minutes beforehand that the hypotension will occur. And in the near future, this HPI will also be available non-invasive. So the current version is relying on the arterial pressure waveform obtained invasively, but in the future we can have finger cuffs like this one, the clear side cuff, and they give pretty much the same arterial pressure signal. So you can also calculate the hypotension prediction index, and the values, as you can see here, are very good. So the higher the HPI, the higher the event rate, and the predictive ability pretty much the same as for the invasive signal. So this is something for the near future. So how will this affect our management? Let's look at this plane. So this is the mean arterial pressure. And in the traditional approach, we just wait until the blood pressure drops below 65. Then we take a treatment, give it here, let's say the vasopressor, and then the blood pressure increases again. But this traditional approach implies that hypotension will occur. We will have an area under this threshold of 65, which is potentially harmful. Now, with the HPI, which is telling us before the hypotensive events at this point that hypotension will occur, when the blood pressure is still normal, we might consider giving the intervention early when the blood pressure is still okay, in order to prevent the blood pressure from falling. And this is what I call a preemptive treatment instead of a reactive treatment. So it will change our behavior, our way of managing hypotension. And does this work? This is again this paper from Germany that I showed earlier in the hip surgery patients. And actually, by using the HPI, they could show that they could reduce the incidence of intraoperative hypotension from 88 in the control group to 48%. So not to zero, but they could more than reduce it by 50%. And they could reduce the hypotensive events from 5 per hour in the control group to 0 in the control group, the duration from 11 minutes to 0 minutes, and the percentage of case time that the patient was hypotensive from 6% to 0%. So this is very impressive, and we wrote an editorial to that because it's a very first important step showing that we might be able to reduce the incidence of intraoperative hypotension to almost 0. Reactive treatment, as I told you, of hypotension may indeed be inferior to a proactive treatment, so treating the hypotension before it actually occurs. There has been another study, this is the HYPE study, also from the Netherlands, looking at 68 patients undergoing a major surgery, and they had this early warning system, which is the HPI actually, in the one group, in the intervention group, and the standard flow track sensor in the control group. And by using this advanced sensor, this early warning system, HPI, they could actually reduce the time-weighted average for hypotension dramatically, significantly to almost 0. So again, a study showing that by using HPI, you can reduce the incidence of hypertension. There's another study published recently, last year, from the Cleveland Clinic, also looking at HPI in 214 patients, so the biggest study so far. And again, they looked at the amount of hypertension at different thresholds. And surprisingly, they found no difference in time-weighted average of mean arterial pressure below any of these thresholds. So the conclusion was that HPI did not reduce the amount of intraoperative hypertension. However, if you look at this paper, and this is what also the authors have to admit, that half of the HPI alerts were not followed by any treatment. So the system was alarming and the doctors did nothing, presumably due to the short warning time, the complex treatment algorithm that they used, or that the clinicians were simply ignoring the alert. But of course, if you ignore the alert or do nothing, then you cannot expect any difference in your incidence of hypertension. So if we avoid hypertension by an individualized blood pressure measurements, we can actually improve the outcome. This is what this study has been showing. Almost 300 patients undergoing major surgery from 9 centers in France. And they had 2 groups. In one group, they called the individual group or the intervention group. It's a blood pressure management was maintained at a systolic pressure between plus minus 10 at baseline. And in the standard or the control group, the blood pressure was only treated when the systolic blood pressure was below 80 or more than 40% from baseline. And they looked at organ function, and these are the results. So in the standard treatment group, they had an incidence of 65% postoperative organ dysfunction, and they could reduce this by avoiding hypertension, again, not to 0, but substantially by 14%. So actually, this is a hint that if you treat hypertension, you might improve the outcome of your patients, and that there is a causal relation instead of just an association. So this brings me to the third question. Why is an avoidance of hypertension better than a correction? The answer options is the correction may imply use of vasoconstrictors without previous diagnosis of the causes of hypertension. B, correction may favor a universal approach, so giving fluids only or vasopressors only. C, avoidance may imply an initial diagnostic approach about the reason of the hypertension. D, avoidance encourages looking at causes and mechanisms. And E, all of the above. So please go to your Slido again and give your answer now, please. All right, let's look at the results. And as expected, the majority of you chose the correct answer, which is E, so all of the above, because the main difference between avoid correction may imply that you give a vasopressor without diagnosing the reason behind hypertension. But hypertension may, of course, have a different reason, like hypovolemia, which should be treated with volume, or depressed myocardial function. And avoidance may imply you look at this diagnostic approach. So is intraoperative hypertension present with different threshold values? Is it severe? Do we have loss of autoregulation and so forth? What are the causes or the mechanisms of hypertension? What is the best treatment? Is my treatment effective and secure? And is a bad outcome avoided? This is what the avoid approach may be better at. And if we are talking about the mechanisms behind the hypertension, we have to realize that there are different mechanisms. The most important ones being a decrease in cardiac preload, so hypovolemia as an example, a decrease in systemic vascular resistance, for example, vasoplegia during or after regional anesthesia, or an impairment of myocardial contractility, because we know that our anesthetics mostly depress myocardial contractility. So we have to find out. And the HPI can help us, because along with the HPI, which is telling us that hypertension might occur, it also comes up with this, what we call the secondary screen with a decision tree. So anytime that the HPI alarms above certain thresholds, or anytime you can press on this button to come up to this screen, you can consult this screen, and it gives you information about the preload, looking at the SVV. And in this case, volume would be the right choice of treatment. It also looks at the myocardial contractility, looking at the DPDT. We will come to that in a second. And if that is a problem, an inotrope might be the best treatment choice. And it looks at the afterload. And if this is a problem, then the vasopressor might be the better choice. So it helps you in deciding. When we start with the preload approach, this is based on is using the dynamic variables, which are based on heart-lung interaction. So the mechanical inspiration gives some impact on the arterial pressure and flow curves. And we can either calculate the pulse pressure variation, which you might all be aware of, or the stroke volume variation. And if these are above certain thresholds, then you might consider giving fluids, because then the patient might be on this steep part of the Frank-Starling curve. And if you increase the preload in such a patient, which is decreasing the SVV, then it will increase the stroke volume or cardiac output. But if the patient has a low SVV, is on this flat part of the curve, then the same increase in volume will not increase cardiac output anymore. The second variable is the DPDT, an estimation of the cardiac contractility. And this is nothing else than looking at the upstroke part of the arterial pressure curve. And if your heart is contracting very well, this increase will be very steep. And if the heart is insufficient and not pumping very well, this increase over time will be slower. So this is called the DPDT, the change in pressure over time. And this gives us a measure of the contractility. The question now is, normally the cardiologists do this by looking into the left ventricle with a tip manometer. But now we are looking at the peripheral arterial waveform taken from the radial artery, for example. So does this correlate with the DPDT that the cardiologists measure in the left ventricle? And yes, it does. That has been shown by this study some years ago in cardiac surgery patients. And they look at the left ventricular DPDT compared to the femoral DPDT, which correlated very well, and even better correlated the changes in left ventricular DPDT with the peripheral DPDT. So the peripheral can be taken as a surrogate. And what does it tell us? It can be used to aid us in the use of inotropes to treat hypotension. We have to realize that we have to look at the individual baseline of a patient and not targeting a specific value. But this probably has the biggest impact in terms of change of our practice. And the third variable that comes up with a secondary screen is the dynamic arterial elastance. What is it? It's just a ratio between pulse pressure variation and stroke volume variation, and it predicts pressure responders, the pressure response in preload responders. So I call it the stroke volume variation of the pressure world. How does this work? So this is a pressure volume curve, and you might have a patient which has a, let's say, SVV of 15, but only a PPV of 10. And if you divide 10 by 15, you get a low value below 1, while if this patient is on this part of the pressure curve, volume pressure curve, even having the same SVV of 15, he now has a PPV of 25. So this gives a high number of dynamic elastance. 25 by 15 is above 1. So this patient will probably increase his blood pressure if you increase the volume. So the clinical questions that might be answered with using the dynamic arterial elastance is, if my patient is fluid responsive, will arterial pressure improve when I give volume to my patient? Theoretical considerations is, if the dynamic elastance is high and the patient is preload dependent, then arterial pressure will improve along with cardiac output when I give volume to that patient. And the greater the dynamic elastance, the greater the improvement in arterial pressure, will be after that volume expansion. So as I said, I call it the stroke volume variation of the pressure world. And this is just summarizing the dynamic arterial elastance approach, how we can use it. So if a patient is hypotensive, just first of all, we have to look if the patient is preload dependent, and we use the stroke volume variation for that. Then we might giving fluids. And if this will certainly increase the stroke volume, that is what we know from the dynamic variables. But if we want to know if this also increases the blood pressure, we have to look at the dynamic arterial elastance, and it will tell us. So this will bring me to my conclusion, to my take-home messages. So I told you that intraoperative hypotension, defined as a mean arterial pressure below 65 for more than 1 minute, is very common, even in flow or volume optimized patients. It is associated with poor outcomes, so myocardial injury and kidney injury, maybe also stroke and mortality. It can be predicted nowadays with the Acumen Hypotension Prediction Index, which predicts hypotension reliably up to 15 minutes before it actually occurs. It predicts hypotension better than any changes in mean arterial pressure or any other hemodynamic variables do. So it buys you time to take measures before the event actually occurs, and it will probably change our practice from reactive to proactive and from an unspecific to a causative blood pressure measurement. Of course, we need more studies to show that if we prevent hypertension, that it has a good positive impact on our patient outcome. But anyway, I hopefully could convince you that HPI is not just a mirror of mean arterial pressure or the changes in mean arterial pressure, but you have to realize that, of course, there are hypotensive events that are not predictable by looking at the arterial pressure waveform 5 or 10 or 15 minutes before it, such as if you give a shot of propofol, or if you activate your regional anesthesia, or if a surgeon puts a major clamp on a vessel. These are acute events that, of course, cannot be predicted by the HPI algorithm. So this is not a failure of the HPI. This is just a different cause of hypotension, which cannot be predicted. With that, I would like to thank you. And here, if there are questions, I do have some cases which we can discuss if we have time and if you are willing to discuss these cases. But this is for the moment, and I would like to hear your feedback, and if there are any questions, I'm happy to take them. Thank you.
Yeah, thanks, Prof. Schreen. That was a great speech, great talk. Yeah, I think it gave us a good insight. Yeah, it gave us a good insight to the incidence of intraoperative hypotension and how it's associated with worse outcomes. And thank you for sharing with us the cutting-edge technology of possibly of hypotensive prediction index that will allow us to change the paradigm of blood pressure, hemodynamic management intraoperative from a reactive to a preemptive mode. Okay, so I am going to now start by just fielding some questions from the audience. Okay, so first question from a colleague in Thailand. Is HPI appropriate in the ICU? And why? And perhaps looking at some of the other questions, the context would be, maybe you could also share with us what are some of the patient or clinical contexts where HPI has been more validated, or the result where we can be more confident of the result.
Thank you for the question. So is it appropriate in the ICU, and why? So why not, I would like to ask. Of course it is appropriate. However, there are no data as of now, as far as I'm aware of. So mostly it has been tested in the intraoperative setting, but of course some of our patients were delivered to the ICU, and we did follow up this. Of course it can be used there. You have to realize, however, that, for example, the left part of the decision tree that I showed you on the secondary screen, which is using SVV to predict preload responsiveness, might not be working in the ICU if the patient is on pressure support, ventilation, or is breathing spontaneously. So if he's not ventilated with an adequate tidal volume. And then this part might be not able to predict if the patient is preload responsiveness, but the HPI as such is still working in the ICU. But as I said, there are no data out there published. So please go ahead and try it and give me your feedback. But theoretically, it works as well in the ICU.
Yeah, my HPI is just coming to Singapore, but I don't think I've actually used it before. But because it's a technology that's derived from machine learning as well as training data sets, my understanding in data science is that the validation environment needs to be very close to the training environment for the data to be extrapolatable. At this point, so I'm just wondering how close the ICU environment would be compared to a perioperative environment where the parameters tend to be more stable. Having said that, yeah, I agree we do need more data, and I'm quite keen to look at some of this data. Okay, our next question would be from a colleague in Singapore. Is the predictive index for hypotension accurate in circumstances such as laparoscopic surgery or patient with AF? I guess this question is related to patients in which dynamic parameters of monitoring such as SVV may not be predictive of volume responsiveness. So perhaps an open chest or open chest patient. Yeah, perhaps you could comment on this process.
Yes, thank you for this question. Again, as I said, for the ICU, so let's start with the laparoscopic surgery. Yes, it works very well also in laparoscopic surgery. However, we use a higher threshold for SVV for laparoscopic surgery as compared to non-laparoscopic surgery. So when we use the SVV of 12 as a cutoff value to decide if the patient is preload responsive or not, we would use SVV of 14% in laparoscopic surgery. So this is the only difference, but the HPI will work as well in those patients. In AF, it's a similar story. So in AF, you cannot use the SVV, or as you might know, for predicting preload responsiveness. So this part of the secondary screen cannot be used. But what can be used is that you give a fixed fluid bolus and see what the stroke volume index does if you want to know if your patient is preload responsive. But the HPI should also work in patient with AF, although it might take longer because it needs more time to look at more waveforms to get to an and you may have more fluctuations in the value. But theoretically, it works also in AF.
Thank you, Professor. Okay, I'll move on to the next question. Okay, I think it is 2 questions loaded in. Okay, how does HPI predict hypotension? Okay, that's one. I believe you referenced that in some of your earlier slides. And are there any prerequisites before HPI can be accurately measured? I think this question is based on the caveats, the assumptions, and the limitations before HPI is accurate, or perhaps are there any patients in which HPI cannot accurately predict hypotension currently?
Yeah, so how does it predict hypertension? It looks at the shape of the arterial pressure waveform. So what you need is a good, reliable arterial pressure waveform. If you have a crabby signal, like a damped curve, you cannot you cannot get a predictive ability. So the signal that you put into the system has to be good. Whether it be invasively derived from an arterial line or in the future from these cuffs, finger cuffs, doesn't matter as long as the signal is good. So for the signal, for the finger cuff, there is a limitation. Of course, if you have a patient on high dose vasopressors or with peripheral perfusion in deep shock, then this method might also not be very reliable. We talked about laparoscopic surgery already and AF. So are there any prerequisites before it can be measured? So you need to have a good arterial pressure signal to put into the system, and then it should work as long as you have that.
Yeah, I think HPI will probably be more useful in patients who are, from a point of a critical care anesthesiologist as well as intensivist, it will probably be more useful in patients in which it's not actively in shock. I mean, if I have a patient who's already on double or triple inotropes, I don't think HPI will bring a big difference to my management. It'll probably be better for a patient that I expect to go well, and it gives me one more warning sign in case the blood pressure falls.
So completely agree that this is, I just wanted to confirm your statement.
Okay, great. Next, this is my own question. I may have missed it in the talk, but what is the definition that HPI use? What do they define as a hypotensive event? Is it any of the earlier definition that you referenced?
Yes. Sorry if I missed that. So it's actually the mean arterial pressure below 65 millimeters of mercury for more than 1 minute. This is the definition that the actual version of the HPI used. So I get also the question from many clinicians, can we change this threshold? Because if you have a patient with chronic hypertension, you might want to choose higher mean arterial pressure values. And in the current version of HPI, this is not possible. But as far as I know, they are working on it to have this ability to choose different values than the 65 that are currently used. But this needs a completely new evaluation. So the whole validation process, the whole machine learning algorithm has to be done then for different pressure levels, because you have to define a non-hypotension and hypertension and look at the different waveform characteristics again for each individual threshold. So it's not that easy, but it will come in the future. But the current version is looking at a threshold of 65 millimeters of mercury for more than 1 minute.
Yes, I agree that an individualized BP target is probably the way to go for the next version or the next iteration of HPI, as referenced by the study from JAMA 2017 that you shared with us, in which individualized goal-directed BP target is probably may lead to better outcome and less organ dysfunction compared to a universal BP target. Okay, maybe I will go to another question. Question of physiology: does BP/DT value, is it affected by the volume status of the patient?
Yes, good question. Yes, it is. As you know, if you preload, if you increase the preload, if you stretch your ventricle, the contractility is better. Yes, so it's a preload dependent parameter, if you will.
Okay, next, a question by eminent intensivist in Singapore. Is the HPI index presented together with other hemodynamic parameters of cardiac index, stroke volume index, SVV, SVRI on the machine?
Sure. I am not sure if I have shown you pictures of the screen, but I can do when we do have time to discuss the cases. Then I will have some screens. Of course, all of them are on your monitor, and you can choose which one to display. I think up to 4 traces can be displayed. So the four ones you just mentioned can be displayed in addition to the arterial pressure waveform on your monitor. But we can see examples when we come to the cases.
Okay, great. Yeah, I have used the Hemosphere, but I have not. I think the version I use does not have HPI yet. Yeah, and I find one of the challenges is actually sometimes there are too many parameters. Yeah, so it is important to avoid information overload by only choosing and displaying the parameters that will meaningfully affect my management. Yeah. Having said that, I think there are quite some useful algorithms to manage the patient. Yeah, what is important, I think, is the understanding of hemodynamic monitoring and how to interpret the parameters rather than just blindly following them in effective intraoperative management. Okay, great. I'm going to go on to another question. Okay, both dynamic elastance and SVR gives information on the so-called afterload of the patient. However, if both figures point to a different direction, which value is more reliable? I guess the audience, the question is which is a more accurate reflection of the afterload of the patient?
Good question. I cannot give you the answer. I can only give you my personal opinion about it. So the dynamic elastance is a new variable. We have to understand it and we have to get used to it. We are still learning, but I think it's quite interesting. The SVR we know about for years. I personally don't like the SVR because it's just a calculated number and not a measured one. So, and it depends on the measurement of cardiac output. So I'm not a fan of SVR, but if you are used to work with SVR, you should use it. This is why they are both on the right part of the secondary screen equally. So you can choose either of them, what you are familiar with. You sure need some time to learn about the dynamic elastance, which is only variable valid in preload responsive patients. I hopefully made that clear. So if patient is not preload dependent, you cannot use the dynamic elastance at all. So and then you have to use the SVR.
Yes, I agree. I've actually been trying to use dynamic elastance intraoperatively also, but to try to gain an insight. And my personal feel is that there's this mysterious concept called afterload. Yeah, and both SVR and dynamic elastance are giving a different look at it. Yeah, which may not always be the same thing. But dynamic elastance gives a better idea of how volume is coupled to pressure in the patient system. That is what I find. And it's still something I'm trying to learn. Yeah, and I must say your talk, even after your talk today, I've learned a lot more about it, and I hope to bring it more into my practice. Okay, maybe we will do one last question before Prof. Sharon would like to share with us some case to illustrate what some of the principles of things that we've gone through today. Okay, so this question is, I can anticipate a change in the patient's blood pressure based on both clinical experience and other early stages of hemodynamic instability and start intervention to defend the practice. So in this case, how would HPI be different? So I think it's the question of the human versus machine kind of question.
Of course, experienced anesthetist is a very valuable tool, and we have in our gut this feeling that this patient will become hypertensive or not. But if you look at the data, and this is what I also found hard to believe, because I thought I'm doing more anesthesia and intensive care for more than 30 years now, and I thought I could predict. But if you look at the data, and I showed you the comparison between mean arterial pressure and HPI, the HPI is much better, which is also logical. It's looking at many features of the arterial pressure waveform, not only one variable like heart rate or whatever. So a combination must be better than every single value, including at mean arterial pressure, to get to such a prediction. And the time is important. So you can predict up to 50 minutes or 20 minutes reliably that the hypertension will occur when the blood pressure is perfectly fine. So the patient has a mean arterial pressure of 85 and stable at 85. No indication for whatsoever. Still the HPI detects some compensatory mechanisms affecting the arterial pressure waveform that cannot be seen by the eye or even the experienced clinician on the monitor, and this is the advantage of the HPI. So it's performing simply better than our eyes and our experience. Sorry to say that.
I agree with you. So my comments would be, I was discussing with some of my radiologist friends on how the machine learning could compete with the human in reading radiology films. And the issue is that the machine is able to see a lot of shades and details that the human eyes cannot see, which may not actually make intuitive sense to the human brain. So it has a resolution much higher than what the human eye sees. Then sharing with what I have read in the popular science about machines playing chess. While it is quite clear that a machine will always win a human in chess, however, if you have an average human player with a very good machine algorithm, it so far is able to outcompete even the best machine and the best human player. So I think we shouldn't look at it as a fight between man and machine, but rather the machine is now augmenting an average anesthesiologist, because I don't think most of us are the top 1% anesthesiologists around. Most of us are just average, or we like to think that we are all above average. So if we do have a bit of more help from a different monitor that can be effective, I think that will bring us back to a competitive level near the top maybe 5 to 10% of anesthesiologists. Okay, so I think Prof would like to spend the last 15 to 20 minutes sharing with us some cases to illustrate some of the principles that he has discussed today. So Prof, may I invite you to share your screen again?
Okay, so this first case I just want to share is a male, 70 years old, 171 centimeters, 91 kilo, so a little bit high BMI, typical Western European population. He comes for a vascular surgery, bypass surgery, ischemic heart disease is in his pre-medical history, myocardial infarction, he has a previous CVA, hypertension, aortic stenosis, renal impairment, so a pretty sick patient. ASA status 3, I would say he's taking the usual medication for these diseases. So let's start. So this is the screen, the secondary screen. We are now 20 minutes into the case after the induction. So the HPI is 100, which is not astonishing because the mean arterial pressure is 60. It's already below the 65. So this is why the HPI is 100. And we have to decide now what is the therapy. So the SVV is 5. So the preload, I would say, is okay. The dynamic elastance is 1.2, which will tell us that this patient will probably increase his blood pressure if we give him volume. And the DPDT is 479, and it has increased in the last minute. So it's not, we have to have the individual value of that patient, of course. So about 2 minutes later, dynamic elastance is raised. So the patient is not fluid responsive as the SVV is 5%. If you look at stroke volume, so this is the primary screen. The stroke volume is 49 milliliter and the DPDT is 535. All right. So what is the right treatment? It's a vasopressor because it's probably not volume. The DPDT is okay, but the dynamic elastance tells us that the patient might need some vasopressor. And actually, here you can see in the trend, the vasopressor actually increases the mean arterial pressure back to 80 now. The HPI is going down, no effect on the stroke volume or the cardiac index. So 4 minutes later, same patient, HPI alarms again. It's now 96. Stroke volume is still the same. Cardiac output has dropped now, however, to 1.5. Mean arterial pressure is 67 now. So it's again close to the 65 threshold. This is why the HPI is very high. And what we have to realize now that the vasopressor shot that we gave, a shot of phenylephrine, was only transient. And now 4 minutes later, the effect is gone. We face another problem. And now the DPD starts to drop. It's 560, but it starts to drop to 370 or 390, as you can see here. So what would be the right treatment in that case? HPI is high, of course, because the mean arterial pressure is low. So this is the case where we can start an inotrope because SVV is still okay, but now the DPDT has dropped. It's telling us that we might use an inotrope because maybe the norepinephrine has impaired the heart. So 6 minutes or 7 minutes later, DPDT has increased again to 529. SVV is still low, and mean arterial pressure is still low. HPI is still high. And again, some minutes later, you can see now mean arterial pressure is gradually increasing. It's now 75, and the HPI is dropping. Stroke volume has also increased with the dobutamine and cardiac index is back to normal again with the dobutamine. So the conclusions from this case is that contractility is often affected by anesthesia, and an inappropriate vasopressor use can worsen stroke volume or cardiac index, although they improve cardiac mean arterial pressure. So vasopressor is not always the best choice, and inotropes are sometimes required, and the HPI and the secondary screen variables can help guiding us to use the appropriate therapy. For example, in our hospital, we didn't even have a dobutamine on the non-cardiac ORs, only on the cardiac ORs. But using the HPI, we realized that this is an additional treatment option and that we are now using it much more frequently as we see the DPDT. Okay, a second case, if you want. Again, a male, 96 years, 180, 95 kilo, typical Dutch operation, lab hemicolectomy and nephrectomy for metasynchronous cancer. Pre-medical history is, chronic kidney disease and hypertension, and he's on a ACE inhibitor. So 17 minutes into the case, we are now, and the HPI is trending high. Mean arterial pressure is 71. Now here, you can see here, 71. HPI is alarming. So there will be hypotension in the future. So we need to consider the secondary screen by pressing this button for more information, which gives us information about the reason behind the hypertension. By the way, in the meantime, HPI is 94 and mean arterial pressure has dropped to 68. So 68 is the mean arterial pressure. If we look at the secondary screen, the stroke volume variation is 15, suggesting that the patient is preload responsive or volume responsive. The dynamic elastance is greater than 1, and the DPDT is 565. So what would be the treatment in that case? Of course, volume, because the SVV is telling us that the patient is fluid responsive and not a vasopressor. So after volume, HPI dropped to 37, mean arterial pressure is now 81, and the DPDT is increased to 605. By the way, you can also see that you can use this, you can leave the secondary screen on your screen and treat your patient based on this screen instead of the primary screen. This is being the primary screen. So 2 minutes later, mean arterial pressure is 85 now, and the hypertension is reverted, HPI is low, and everything is fine. Stroke volume variation has dropped to 10. Another minute later, DPDT is 700. So this is one of your questions. Does volume also affect the DPDT? Yes, it does. Stretching the ventricle is good for inotropic support. Mean arterial pressure is now 83, and the HPI remains low. So the conclusions from that case is the raised SVV is the threshold for giving fluids, and we used a higher threshold because there was laparoscopic surgery of 14. The EA, the dynamic elastance, only predicts pressure responsiveness when the patients are preload responsive, and the contractility frequently decreases during anesthesia. So it's important to keep an eye on that, as this will guide therapy. Okay, another case. Again, a male, 69 years old, 170 centimeters, 90 kilo, too heavy for his size, typical Dutch. Surgery, emergency laparotomy for perforated diverticulum with fecal peritonitis, pre-medical history, ischemic heart disease, hypertension. He's on a beta blocker, aspirin and nitrate. Again, 20 minutes in the case, HPI starts to alarm here, but all the other variables are in the normal range. So stroke volume is 76, stroke volume variation is 7, mean arterial pressure is 72. So the question is, should you treat such a patient at this point? Of course, we don't treat only numbers, but the number is telling us that the patient might become hypotensive. So we just wait. And 5 minutes later, the HPI is still alarming, very high now. The mean arterial pressure has dropped to 67 now, but still stroke volume variation is normal. Stroke volume is pretty high, so it's normal. And we cannot see anything on the secondary screen that helps us treating this patient. So this is, again, this occurs, and so we have to wait and evaluate the patient. So another 3 minutes later, the HPI is now 100, so maximum. Mean arterial pressure has dropped below 65, it's 64 now. Stroke volume variation is still low, it's 7, because telling us the patient is not fluid responsive. The DPDT has also not changed. So this is also not a case for inotrope, and the dynamic elastance is low. So you might consider giving a vasopressor, as all other variables are in the normal range. So a minute later, after the vasopressor, phenylephrine, mean arterial pressure has increased dramatically. So maybe we overdosed our vasopressor a little bit. HPI is dropping down. Stroke volume is still fine. SVV is still low. 6 minutes later, HPI alarms again. Blood pressure mean arterial pressure is 71 now, but still SVV and stroke volume are normal. So HPI, and again, we give a vasopressor, which is titrated to get the mean arterial pressure back up to 79 here. HPI has decreased to 54, and blood pressure is again. So conclusion from this case: appropriate treatment of hypertension and titration of vasopressor therapy to affect variables on the secondary screen may often be normal and not helpful, but HPI is high because we are 15 minutes before that hypertension, and everything is normal at this moment. So this happens. So you just have to wait, monitoring these variables over time to get a hint how to guide your therapy. And this is the cases that I want to share with you.
Thanks, Prof. That was very illustrative. Nothing like a clinical case to put everything together. All right, so I'm going to do a wrap up. So as they say, in the Valley of the Blind, the one-eyed man is king. So now I guess the data over the next few years will go on to tell us whether HPI is indeed the monitor we have all been waiting for, and whether it can be coupled to an effective intervention that can affect outcome. All right, Prof. Schreen, last question to you. Do you think you can give us some comments, some final comments on HPI? With all this intelligent innovation, what do you think would be the outlook for clinical practice in the next few years?
So it will completely change our management and our way of thinking. As I said, from a reactive treatment, waiting until the hypertension occurs and then treat it, to a more proactive way. Of course, we have to see if we are not over-treating patients, because giving a vasopressor to a patient who will never be hypertensive is also risky, because all of these drugs have side effects, of course. So we have to see if the outcome is positively affected. As I said, we need data for that. But we are now currently doing a study where we look at the behavioral changes in our minds, among our colleagues. And this is dramatically changing the way we look at hypertension, and we realize that this is a problem, and we treat the patients. And as I said, the inotropes is just one example. We are using much more inotropes, less vasopressors, maybe less fluids, but earlier fluids than previously. So this is a dramatic change in our approach to the management of our patients, thanks to HPI and the screen.
Yeah. Okay. Thanks, Prof. Schreen, for spending your morning with us. I certainly think, I hope you have had a good coffee and you're looking forward to your breakfast. So with this, I'm going to hand over the slideshow to Hansel from Edwards, and then he will take over from now. Thank you, everybody.
Thank you.
Hi. Thanks. Really appreciate it, Prof. Schreen and Prof. Ng. Really insightful, really illustrative. So a shout out to all the audience today. As part of the continuity of what a fruitful discussion we have we would like to take this opportunity to let everyone know that later this month on the 20th, we'll be hosting a virtual physiology lab. This is a session where Dr. Davis and Dr. Myton will be discussing live on the use of the predictive and advanced parameters that Prof. Schreen has just shared with us. We are using earlier recordings of live porcine as well to illustrate its clinical application. So feel free to reach out to us if you're interested, and we will also drop you a note as well, an email after this if you would like to sign up for right away. So before that we let everyone go, I know that it has been a long Saturday. We really appreciate your feedback where we can improve. The speakers are also very keen to hear from you as well. So please feel free to scan the QR code over here. We have always been looking forward to continuously serve you better throughout all our virtual clinical education courses, even moving forward. And stay safe and stay well. And once again, thank you so much to Prof. Schreen and Prof. Ng. And we hope that we get to see each other again. Take care.